I welcome Dr. Sanant Kumar Das, my course co-director and 360 Critical Care co-director. Dr. Sanant from Australia. And Dr. Sanant, would you like to have something right now, some discussion?
Yeah, hi. Good evening, everyone. My name is Sanant. So we're just gearing up to start. I think another 3-4 minutes. That's when the exact start time is. So basically, this is the course aimed at preparation for EDIC 2, and we have formulated this course in a way that it covers most of the aspects of EDIC 2 exam. This is a rigorous around 4 months, 3.5 months preparation time, which you should be using it to the best possible way you can. And we are just a pair of helping hand to guide you what to read, what to study, and give an idea what the examiners expect you in the exam, what should you be answering, how you should be answering, because at this level of your career, most of us know a lot of things, but in the exam, you need to put things into perspective. So you have a very limited time for answering questions, and you should know how to use that time maximally so that increases your chances of success. Now this is the 4th time we are doing it. I think more than 250 students have enrolled till now, and there is a staggering response to this course, and the success rate is pretty high. I would not take the credit for the success because it is the candidates who have been very, very punctual, very, very meticulous about going through their study. That's what counts in the exam, rather than whoever teaching whatever. Does make a little bit of difference, but it is the effort from the candidates to turn up every Saturday or Sunday whenever the debrief, to listen to the mentors and the faculties. That does help in the exam, and it is a matter of 2 or 3 questions between passing and failing. So that's what is the main thing that we want to highlight, that you need to know the tricks of the exam. How do you approach a question, how do you answer a question, and how do you make maximum use of your time that is given to you. At the same occasion, I want to thank a lot of faculties, around 30 plus faculties, who are going to join us in different stages of this course, and the mentors, around 15 mentors, I guess, whose input are very, very important, very, very valued in this course. They have been previous mentors, they have been previous faculties here, they have been coming over every year to help out the students. And my sincere thankfulness to them for their effort and the time they put in. I wish all of you a happy learning experience from now onwards till you appear the exam. And we are here to help you out, whether you are really registered to the course or not. Irrespective of that, you have our contacts there. We are very happy to pitch in anytime if you need any help. Thanks, Tapas. That's from my side.
Dr. Sanant, are we having the recording on?
Yes, it is recording now.
Okay. So
recording in progress.
Hello. Yeah.
Yeah,
so
Tapas, go ahead. You can hear.
Yeah, I would request everybody for the time of our discussion to mute their speakers, so that there would be uninterrupted discussion, and people should be getting all the ideas what we are discussing, rather than there would be any disturbance in between. The second point what I want to highlight, just to add with Dr. Sanant, the marking, the passing is almost, you would say, there are candidates, there are experiences from our own academy also. People have been unsuccessful with just 0.5 marks. And that's the reason from this time onwards, they are not sharing the total marks. They are just saying you have cleared it or not. because there were so many queries to the European Society, the EDIC exam forum, that why the 0.5 mark you are not considering. So I would request everybody that the battle is really fierce, and you have to be on your toes. It cannot be like taken granted that yes, I have scored this much of marks in my training period, so it's another exam, I would be also clicking it. No, because the format is really like every year they're changing the format, and that's the reason why we have also changed our format this time. We have made it more of like clinical, bedside, and little bit of difficult. We have increased the difficulty level to the next, I would say, compared with our 2 to 3 last like the classes what we had in last 3 months. So that's why we want to prepare you before, so that in the real exam you won't feel the heat. So that's the experience from our all mentors as well as the examiners, that yes, the level is right now really very hard for the EDIC part. For today's discussion, very learned Dr. K.R. Ramanathan, who is the chief of cardiac critical care, as well as the program director, the fellowship director of National University Hospital, Singapore. He has vast experience in cardiac critical care, and he's also very active in ELSO, and he's also having so many publications about ECMO. So he would be joining at any point of time because he's having his hospital on duty, but still he's from Singapore, will be joining, and he would be definitely sharing his experience with us. And with us also today, Dr. Sushruta Bandyopadhyay, who is Director Critical Care, Amri Hospital, Salt Lake, Kolkata. Very vast experience in the cardiac critical care, and big expert in the echocardiography. So without wasting further time, the CCS first one would be discussed by me, and then Dr. Sananta Das would be discussing the CCS part 2. And I would request everybody, whoever is having any queries, please post in the chat box. So let's start with the CCS clinical vignette 1. The questions would be coming like this. You would be given 5 minutes time before you would be appearing the real exam in the EDIC part 2. So the first clinical vignette with you, they would be sharing with you 5 minutes before the exam. So the first CCS is about cardiology, and see how the questions from the CCS vignette 1, 2, it would change to other domains. So that's the beauty of our discussion. We would be giving you the real experience of the EDIC part 2. So the first clinical vignette 1, the question starts like this, and this would be also your exam paper. So believe that you are now appearing the EDIC part 2, and the examiner is in front of you, and I am the examiner, and I am sharing this clinical scenario with you 5 minutes before your question answer session starts. You attend an emergency call in your hospital's acute medical unit during daytime hours. On arrival at the spot, a 34-year-old female, Mrs. XYZ, appears tachypneic, respiratory rate of 30 breaths per minute, with saturation 96% on 15 liters per minute oxygen therapy. She is tachycardic, 110 beats per minute, with a blood pressure of 120 by 70 millimeter mercury. She is febrile with a temperature of 38 degrees centigrade. XYZ is alert and able to answer questions appropriately, but finds it difficult to complete sentences due to breathing difficulties. She also complains of left-sided chest pain that came on abruptly, which is affecting her ability to take deep breaths. And there is also a swollen left calf that is painful on palpation. Measures to stabilize XYZ have already been initiated. Now, I would be starting with 2-3 important points from this vignette 1. First of all, these are all real case scenarios from the European ICUs. The second point, they would not be discussing about some historical or something which are not very, you can say, practical. So, as we dissect further, before going into the questions that have been shared to the candidates 2 days before, let's scan and keep in mind So the clues to how you should approach the real exam, I have made little bit of changes here. So once you get these scenarios in your laptop or your desktop screen, rather than going into all those 10 lines, you have to scan few things which are relevant to your the discussion. And as responsible and attendings who are practicing real critical care, we expect as examiners that you should scan the important messages what the examiner wants to convey to you. So here, if I would dissect and scan 34-year female, acute medical unit, tachypneic, saturation 96% and 15 liter per minute oxygen, tachycardic, blood pressure is 120/70, which not very alarming right now, but she's febrile, consciousness is okay, but there is also complaint of left-sided chest pain. And most important for me, as I am practicing critical care for last 4 or 5 years, and I am practicing to clear my EDIC part 2. So the examiner expect that you should read the most important line or two from the clinical case vignette 1. So here I would find swollen left calf that is painful on palpation to be the most striking. So this is the scan, and you should do for every clinical vignette you get in your laptop or your screen, your desktop. Now, the questions would come straight after you see and go through in 2 to 3 minutes. And the first question would be, what could be the most likely causes of deterioration in this case? So the questions would be straightforward differential diagnosis, or what is in your mind going on, what should be the clinical diagnosis, something like this. It won't be like what would be the percentage of the cases, what would be the the clinical features. No, it would be more of clinical. And when you answer, we would suggest you to have a structure in your mind rather than going from here and then entering into something else and then trying to cover everything, but no flow. So the examiner don't find it interesting to read or understand if you are so haphazard in your answer. So that's why always in our academy, in our debriefs, we expect our candidates to go through one structure. So here, if I would be asked this question, so I would first start with the respiratory, because the respiratory is the striking thing for me right now. And the first thing what would be coming in my mind, pulmonary embolism. And it won't be the straightforward answer. Rather, I would also add from respiratory system, pneumonia, acute asthma exacerbation. I don't know the exact history. Spontaneous pneumothorax, because it has happened very acutely, and there is also left-sided chest pain. So maybe these would be my differential diagnosis from the respiratory domain. Now, coming to the cardiovascular, the striking things that would come in my mind is acute pulmonary edema, acute myocardial infarction, and aortic dissection. So these three things would be in the cardiovascular. In others, chest pain, sudden deterioration, febrile, respiratory distress. So maybe there would be some differential diagnosis would come from the gastrointestinal perforated viscous acute pancreatitis. But the answers, if the examiner would be there in the EDIC part 2, they would be any plausible cause, but must include pulmonary embolism and acute pulmonary edema. So if you start from aortic dissection, then acute myocardial infarction, but pulmonary embolism you will forget, maybe they will not give you a single mark. So it's doubtful. Though there would be also, if there are 4 marks, you get you expect that yes, I have uttered the word aortic dissection, myocardial infarction, but somehow forgot to utter the pulmonary embolism. But the examiner may be very strict in not giving you a single mark, because pulmonary embolism you should not miss, because your diagnosis and your management are if you diagnose well, then only your management will follow. If you will not diagnose that pulmonary embolism is your first differential diagnosis, definitely the next things will not come into your mind. Now, what is the most probable diagnosis in this case? It's a straightforward question. So if you do not know, now you'd be in confusion, and the answers would be like your like marks may be acute pulmonary embolism, they may give you a 4 marks straight, one answer here. What is the most probable diagnosis in this case? Now, going further, the third question would be, how do we define hemodynamic instability in acute high-risk pulmonary embolism? The question straightforward asks you how you divide the hemodynamic instability if you are suspecting that C is a high-risk pulmonary embolism. So it's a clear definition. It is a clear classification. So you have to start with, maybe the patient will present with cardiac arrest. Maybe the patient will present with obstructive shock, and the obstructive shock here would be systolic blood pressure less than 90 millimeter mercury, or vasopressors required to achieve a systolic blood pressure 90 millimeter mercury despite whatever you have done for the fluid resuscitation, and you are still getting evidence of end organ perfusion. So that is the obstructive shock in a case of high risk pulmonary embolism. And third one is persistent hypotension, and in that the systolic blood pressure less than 90 millimeter mercury, or systolic blood pressure fall or decrease 40 millimeter mercury that lasts longer than 15 minutes and is not caused by the other confounding factors like new onset arrhythmia, hypovolemia, or sepsis. So this would be the, you would say, definition of hemodynamic instability in acute high risk pulmonary embolism. So this would be the third question. Now, there would be another question the examiner would like to ask. What are the risk factors that increase your risk for VTE? In that, he is pointing towards there is pain in the lower calf. So definitely there is suspicion of venous thromboembolism. So the questions you have to answer in, again, certain headings. It cannot be mechanical ventilation, age, obesity. So it will be confusing, and you will like miss many important etiology if you will not follow certain structure. So in this case, I would be dividing my answer into genetic risk factors, acquired risk factors, ICU related risk factors. In genetic risk factors, protein C and S deficiency, antithrombin 3 deficiency, factor 5 laden mutation. So maybe she is a 34-year female. Again, in the childbearing age group, she may present with the acute pulmonary embolism with the background history of phospholipid syndrome. So that could be. So in that, genetic risk factor plays a very important role. Now, coming to the acquired risk factors, age, obesity, previous venous thromboembolism, history of malignancy or having current malignancy, vasculitis, pregnancy, hormone replacement therapy, OCP. So everything falls into this, this patient's history, because the presentation also, maybe she's taking something like this, or maybe she's having pregnancy, we don't know. So in case the examiner wants to know that whether you are trying to divide your answers into proper risk factors, then definitely you will fetch 100% marks. Now, ICU related risk factors, if the patient is in ICU, we normally deal with this type of patients day in and day out. So in this, prolonged immobility, for example, mechanical ventilation, paralysis, sedative drugs, femoral venous catheters, inappropriate dosage, or lack of thromboprophylaxis. So in this, you can divide your risk factors for the VTE into 3 parts, and the answers are right now here. So in case you answer 1 or 2 important points from all these 3 points, you will get 100% marks. And the marking happens here. So there is normally one examiner who would be with one iPad, and depending upon your answers, you would be ticking. And every answer would be having 1 or 2 marks. Now, the next question which we do at the bedside, immediately, what role does echocardiography have in the workup for diagnosing PE? Again, the answers are very straightforward because we do every day, and the examinee is expected to show his the expertise in performing bedside focus for ruling out or ruling in pulmonary embolism. So that's why the question is framed like this. So in this question, I would again divide into two parts: echocardiography, role, diagnostic modality, management decision. In diagnostic modality, the answer would be again divided into rapid bedside assessment in a hemodynamically unstable patient, where I am not getting the scope to perform or send the patient for CTPA, which is the gold standard for ruling in your pulmonary embolism. Now, CTPA is CT pulmonary angiography. Now, there is also another diagnostic modality here, that coexisting other cardiac abnormality along with pulmonary embolism. If there is also suspicion of some amount of LV dysfunction, valvular abnormalities such as TR in the acute pulmonary embolism scenario, pulmonary pressure, volume status. Because everything, if you are doing right now with the ultrasound or echo here, that would be having some or other like effect on the final management. Now, coming to the management discussion, existence of right ventricular dysfunction on echocardiography is a criteria to think seriously about thrombolysis, because that is one of the prognostic indicator for the recovery as well as the morbidity, mortality of acute pulmonary embolism treatment. So if your patient is having right ventricular dysfunction, definitely 60% chance this patient would deteriorate further. But if the patient is still not having right ventricular dysfunction, maybe there is chance of 10 to 15% of severity. Now, questions again, if we are discussing about echocardiography, the next question would be, what are the features on the 2D echo to suggest the diagnosis of PE? Now, in this, we normally tend to have 1 or 2 points, but you have to remember the most important things along with the RA-RB dilatation. People start talking about RA-RB dilatation and Mackennal sign, but these are not the only things that you should know or understand. So here, if the question would be the 2D echo finding of pulmonary embolism, so it would start with decreased right ventricular regional and longitudinal function, increased right ventricular size. Believe me, it's found only in 25% of patients. Tricuspid regurgitation, abnormal septal wall motion, that would indicate right ventricular pressure overload. Mackennal sign, this is where we all know right ventricular mid free wall becomes dyskinetic, but the apex and the base would be somehow spared. So relative sparing of the apex and base, Mackennal sign. Now, if you are getting mobile thrombus located in the right ventricular right heart cavities, so it's a telltale sign of severity of your acute pulmonary embolism, and that is associated with high mortality. Distended non-collapsible IVC, we all do it, we all know, but in examination, we also have to tell along with the findings of the cardiac echo. And the final thing, 60/60 sign, I would be showing you the picture. How does 60/60 sign normally is calculated? So it's a simultaneous finding of right ventricular systolic pressure as well as pulmonary artery systolic pressure. Both have to be less than 60 millimeter mercury. Now you are getting your right ventricular acceleration time less than 60 millisecond with your the right ventricular systolic pressure less than 60 millimeter, and that you would be calculating from the TR jet velocity. So how does it look like? I'm just showing it for your understanding. This is the 60/60 sign of pulmonary embolism. So it consists of two things. The first one would be right ventricular systolic pressure, and right ventricular systolic pressure consists of two things. Again, one is your TG, that is tricuspid gradient, and the second one is right atrial pressure. The tricuspid regurgitant you have to calculate by this, you have to do the proper transthoracic echo, and right atrial pressure you have to measure the IVC. If it is more than 2.1 centimeter or less than 2.1 centimeter, you have to also measure the collapsibility, whether it is less than 50% or more than 50%. Based on the permutation combination, you will get the right atrial pressure. So if your right atrial pressure is 15 millimeter mercury, how it will be calculated? You will get your IVC measurement more than 2.1 centimeter and collapsibility is less than 50%. So in that, it would be the maximum, that is 15 millimeter mercury, right atrial pressure. So that would be added with the tricuspid gradient, which is 4 into TR max whole square. So if it is less than 60 millimeter mercury, that suggests your acute pulmonary embolism. Now, the second point would be pulmonary acceleration time. So if it is less than 60 millisecond, it suggests your acute pulmonary embolism. So just remember, for the sake of your, like, if somebody is preparing for EDIC part 1, so again, they may be asked like MCQ 60 by 60 sign, and in your like EDIC part 2 also, they may ask you what do you mean by 60 by 60 sign. And these are like in short, if you want to remember as a like in a pictorial way. So you start from here, right heart mobile thrombus to look like this. Dilated RV, again, it has to be the ratio, the basal RV and LV ratio more than 1. Enlarged RV, the plaques view, we all know, we all do it at the bedside. In M board, you will get large non-collapsible IVC here. Then in the parasternal short axis view, you will get D-shaped septum in the systole. Right ventricle takes more like the ratio than the left ventricle. Here I have told about the 60 by 60 sign. Also, you will get decreased TAPC in the M mode and decreased peak S- velocity of tricuspid embolus. Just for the sake of getting into detail of the transthoracic and transphageal esophageal echocardiography finding in acute pulmonary embolism. Now, there are certain things you may be asked in your like clinical case vignettes. Here, I am just trying to summarize everything. They may ask you what are the other blood tests that could aid in diagnosing your pulmonary embolism. So in that, we all know hypoxemia, increase A minus A gradient, which is alveolar arterial gradient. But these are only present in, I think, like almost 60% patients. Here it is like, you will say 24% of patients, the PaO2 is normal, because only we say that hypoxemia has to be there. No, PaO2 is normal in approximately 14 to 24% of patients. Third point, decreased carbon dioxide level if the patient is tachypneic. So in case like you won't get always the increased arterial carbon dioxide, but you will mostly get decreased carbon dioxide or PCO2 of like you will get the respiratory alkalosis in almost 40% of patients because of the tachypnea. But there would be also instances you will get increased arterial carbon dioxide, in which case large pulmonary embolism due to increased dead space. So just for the sake of completion, you should remember what are the blood tests in the ABG findings you should remember. Now serum D-dimer level, we all know if you are not getting serum D-dimer to be high, maybe additional diagnostic testing is not necessary. It is not, as per the literature, it is not recognized that, it is recognized that the frequency of venous thromboembolism is not increased in subsequent 3 months. Coming to the cardiac biomarkers, troponin I and troponin T levels are elevated in 30 to 60% of patients only. But if you are getting elevated troponin concentration, they would be indirectly or directly hinting towards increased risk of mortality in both like unselected patients as well as hemodynamic stable patients at presentation. So you have to have a like serial troponin in those patients to know whether the patient is deteriorating further or not. Now, high sensitive troponin T assay have a high negative predictive value for excluding adverse in hospital clinical outcome. Now, coming to the B-type natriuretic peptide, that is BNP or NT-proBNP, so they also reflect the severity of RV dysfunction and hemodynamic compromise in acute PE. So you need to also read about these cardiac biomarkers, not only in acute MI, rather in pulmonary embolism. Now, I think we are finished with the CCS1. The most important questions that can be asked also I have added, so that you would be understanding the concept of pulmonary embolism. Dr. Sanand, at this point, any questions?
No, Tapas, I think you have explained the things pretty well.
Yeah.
You continue with the CCS.
Yeah. So coming to the clinical case scenario, vignette 2. So in real exam, you won't get much time for the clinical vignette 2. In vignette 1, you would get at least 5 minutes of time. So you have to be in hurry. So at this point of time, XYZ begins to deteriorate further. She appears drowsy. She now has a sustained hypotension 80 by 40 millimeter mercury. We expected that the question will not come straightforward like this. So you have started with fluid boluses over the past 20 minutes, but the BP is dipping further. Now, You did the focused echocardiography at this point of time, and you found there is dilated right ventricle with impaired systolic function. And her arterial blood gas at this point of time, pH of 7, PaO2 6 kilopascal, PaCO2 11 kilopascal, bicarbonate 11 millimole per liter, lactate 7.4 millimole per liter, potassium 5.1 millimole per liter. The chest radiograph immediately done, which showed almost normal, and she was immediately shifted to medical ICU. Now, at this point of time, before going into the further questions, I would be adding few things for the examinees. Now, there is a little bit twist here. We are more familiar with the millimeter mercury, but in examination, you have to know all the conversion factors which are important for the bedside practice. So I have already told you don't have time to scan much here. You have to know what is happening and remember the conversion factors from the kilopascal to millimeter mercury and millimole per liter to milligram per deciliter. So you cannot ask them that please provide me the conversion factor. So they expect that the blood gas, then the electrolytes, urea creatinine, all these things important bedside, like whatever we do regularly, you should know the conversion factors. Now coming to the clinical scenario questions. What are your immediate concerns after shifting to ICU? So the patient was shifted to medical ICU. So the answer would be, for me at this point of time, I have to think about intubation and protecting the airway and the gas exchange. Mechanical ventilation, I have to put the patient on mechanical ventilation. I have to go ahead aggressively with hemodynamic stabilization with titrated fluid and vasopressor. Believe me, rather telling about that, I would do echocardiography, then I would see, I would watch on the lactate. Rather like expanding your answers and taking much of your time, you can just finish everything and the examiner will get to know that yes, this candidate knows everything. Hemodynamic stabilization with titrated. So this word is enough for the examiner to understand what do you mean by titrated fluid and titrated vasopressor. Now, advanced hemodynamic monitoring, that again, like 3 words, but it says a lot. Advanced hemodynamic monitoring is not only about APG or your like simple ECG or like SPO. So you have to think about at this point of time, I would put arterial line, I would think about IABP, I would think about something else. So this would be rather telling about A to Z. I would be only tell about advanced hemodynamic monitoring. Now, plan for definitive management. Everybody will agree with me that in acute pulmonary embolism, when the patient is sinking in front of me, I have to think about the diagnosis. Also, simultaneously, I have to think about the stabilization. It has to go hand in hand. So in this case also, you have to also right now at this point of time, think about the definitive management. In definitive management, you have to again divide into, I have to divide into which type of pulmonary embolism I am treating, risk stratification, and also the suitability for the thrombolysis or catheter directed therapy or only anticoagulation. So here definitely the examiner would know that yes, you know about the contraindications of thrombolysis also, you know about the time spent or like time has already lost in your diagnosis, whether the patient would be the right candidate for thrombolysis or embolectomy or only anticoagulation. So the answers has to be very short and crisp. Rather than taking much of the time, you have to only tell about the points and you will fetch almost 90 to 100% of marks. Now, the next question, which ECG abnormalities are associated with poor prognosis in patients diagnosed with pulmonary embolism? So it's a straightforward question. We all know. So we won't take much of our time. Tachycardia more than 100 beats per minute, new and complete RBBB, atrial arrhythmias, for example, atrial fibrillation, ST elevation in AVR, S1, Q3, T3, anterior ST segment changes, and T wave inversion. So these are the ECG abnormalities. If you tell about 3 to 4, you will get 100% mark. What is the rationale for ordering a chest radiograph? So the examiner wants to know whether you are taking chest radiograph so seriously or you are not taking into account chest radiograph. So the point number 1, I would be doing it to investigate for some other causes for this type of presentation. And this chest X-ray would appear normal in up to 1/5 of patients. So 20% of patients, the chest X-ray would be absolutely normal. So this would like finish my clinical case scenario vignette 2. Now I have added few things just for the sake of completion. Which electrocardiograph like abnormalities might be found in pulmonary embolism? So we all know non-specific findings is the answer. Non-specific findings, and up to 70% they present with the tachycardia, sinus tachycardia, and non-specific ST segment changes or T wave changes. The classic S1Q3T3 pattern and new incomplete RBBP occur in only less than 10% of patients. So you should not take it so seriously. Now, let's go to the clinical case scenario vignette 3. Now you have intubated the patient perfectly. You are very good at that. Now this patient XYZ is placed on mechanical ventilation with aim of avoiding high plateau pressure. Central line is sighted. Noradrenaline infusion rapidly rises to 0.6 microgram per kg per minute. After 30 minutes following the intubation, her BP remains low at 85/40 millimeter mercury. Saturation is 90 to 92% on FiO2 of 1. She is now more tachycardic at 130 beats per minute. Now you did one more clinical examination and bedside lung ultrasound to rule out any other thing that has happened post central line to rule out pneumothorax. Urgent CTPA has been done with due risk explanation to the family as well as to the clinical team that revealed massive PE with evidence of RV dysfunction. So here we are coming to straightforward to the final diagnosis which we have talked in the first CCS clinical vignette 1. Now, the question would come from the examiner now. You don't have time much. What are your main treatment priorities at this point? So the answer would be thrombolysis or embolectomy. So the greatest benefit is seen when thrombolysis is given within 48 hours of symptom onset. And in embolectomy category, in patients who have clear contraindication to the thrombolysis, the emboli can be removed surgically or using a catheter. So the answers would be thrombolysis or embolectomy at this point of time. These are my priorities. Now, the next question would be, what are the absolute and relative contraindication to the thrombolysis? I'm not going into detail. You have to read and you have to remember at least 4 to 5 important absolute contraindications. Ischemic CVA within 3 months, known malignant intracranial neoplasm, known structural intracranial cerebrovascular disease, prior intracranial hemorrhage, suspected aortic dissection, active bleeding, recent spinal or neurosurgery, recent significant closed head or facial trauma. In the relative category, age greater than 75 years, anticoagulant therapy, pregnancy, recent internal bleeding, CPR more than 10 minutes, dementia, major surgery within 3 weeks, history of CVA within 3 months. Now, we would be now going into the CCS clinical vignette 4. The decision is now made to administer altiplage. She has urgently received initial 10 milligram bolus over 1 to 2 minutes, followed by 90 milligram IV infusion over 2 hours. She was continued on high dose noradrenaline and adrenaline infusion. Patient was oliguric on the time of admission, which progressed to anuria. Repeat ABG revealed worsening metabolic acidosis with rising lactate. You have started with sodium bicarbonate infusion. Again, you decided for CBB SD because of this worsening acidosis as well as rising lactate and on high vasopressor. Now, continued cardiogenic shock and lack of lactate clearance and hemodynamic improvement and onset of MODS prompted us to initiate peripheral VA ECMO. So this summarizes the clinical vignette 4. So now I would be taking just a pause that from pulmonary embolism, now they have entered into another important aspect of cardiology and cardiac surgical critical care, that is VA ECMO. So now the questions would be, again, from the pulmonary embolism, now the focus would be, what are the indications of VA ECMO in general? So again, you have to divide, you have to have a structure, start with the cardiogenic shock in the background of ACS, stormy or malignant arrhythmia, myocarditis, and pulmonary embolism. So our patient falls into this category. Cardiac trauma, post-cardiotomy, that is inability to wean from the cardiopulmonary bypass, post-heart transplant graft failure, as a role, like it has a strong role in the bridging therapy, whether to transplant or whether to like VAD, ventricular assist device, drug overdose, anaphylaxis. So you have to remember at least 2 points from each category. What are the indications of VA ECMO in general? Now, what are the unique complications with VA ECMO? So that is the next question. And in this, we all know limb ischemia, but there is another important and peculiar complication with the peripheral VA ECMO, that is LV distension. So, though we may find it little bit difficult, but the questions can go into detail of ECMO, which is right now used extensively in European ICUs as well as many other country major centers. So for that, you have to know in detail about ECMO, because there were questions in the recently concluded EDIC part 2 and the questions were straight from ECMO. So that's why we have put this clinical scenario. Now, what do you mean by LV distension? So the LV distension, when you have done the peripheral VA ECMO, so there will be two possibilities. The forward flow would be also right now like not being done properly because of the poor contractility of LV, and also there is like the antegrade blood flow through the mitral valve. And I would explain what you mean by LV distension in detail. Now, how do you detect it, the LV distension? So you have to do frequent echocardiography. Minimal opening of your aortic valve will find in the echocardiography. You have to do daily chest X-ray, and in that you will find typical pulmonary edema picture, enlarged heart border, increase wedge pressure and pulmonary artery pressure, and you have to also monitor the hemodynamics, the pulmonary artery systolic pressure, then the graphs. Then you have to also know the echocardiographic, all the measurements. Now, for the LV distension, how do you manage that? If you are getting that, then the patient will not be like recovering from the ECMO so easily. So for that, you have to decongest your heart. So for that, you have to know what are the management protocol for the LV distension. The first one would be reduce the afterload with vasodilatatory agent if your MAP is permitting. Second one would be some inotropic agents to increase the LV contractility in a little bit of better way. You have to think seriously about the diuresis and ultrafiltration. And in this patient, CVVSD would be helpful for decongesting the LV distension. IABP, you have to think about increasing the diastolic augmentation, catheter-based pump, and in like refractory cases, you have to think about surgical maneuvers. And for that, you have to do first atrial septostomy to reduce the LV congestion, and also you have to do the LV decompression directly by opening surgical LV venting. So these are the things that would be helpful if you are getting LV distension. Now, 2 points I want to highlight here in the CCS clinical vignette 4. Thrombolysis is deemed unsuccessful if the clinical instability is persisting, and after 36 hours also your RV dysfunction remains unchanged. And there is another terminology the examiner may wants to know, and they may put in the questions, CTEPH, that is chronic thromboembolic pulmonary hypertension. So the patient after recovery from this acute pulmonary embolism, maybe they would be presenting in later time shortness of breath and reduced exercise tolerance within 2 years after the initial event. So the patient would be presented with peripheral edema or exertional chest pain. Those are some or other symptoms of RV dysfunction. So coming to the LV distension, for the candidates who are still not very clear and they are not very familiar with the ECMO. So here 2 things are happening. I would be taking the help of my presentation. So LV distension, the VA ECMO, what has happened here, the ECMO, all these apparatus, the catheter, that would be generating increased afterload in the aorta, and the LV is like right now weak. So the impaired LV has to pump against this supraphysiologic afterload. So that is the problem. Now, the LV may not be able to generate sufficient power to eject the blood, and the aortic valve remaining closed throughout the cardiac cycle. So definitely that would create the stasis, the stagnancy of the blood in the LV, and as a result, what would happen? There would be elevated pulmonary artery pressure, resulting in the pulmonary edema, and ultimately the LV recovery is getting hindered. So that is the explanation of LV distension and the prognosis if you are getting LV distension without doing nothing, like right now anything. I have explained about the two things. Now the question should be how to manage. I have already explained. Now this is one article I want to share with you all. In 2015, you have to read like the indications and complications for VA ECMO in detail. You may get enough like literature and like all those images to like get the idea what do you mean by LV distension. Now this is VA ECMO. I don't want to go into detail, but contraindications for VA ECMO also you want to know: unrecoverable cardiac function, patients who are not candidates for transplantation, chronic organ dysfunction, prolonged CPR without adequate tissue perfusion, and also with compliance limitations like financial, cognitive, psychiatric, and social limitations. So there is one thing what I want to share with you. The PTT has to be 60 to 80 seconds to prevent the circuit thrombosis. Now coming to the next clinical vignette, here it is written like wrongly, but it is now the fourth one. Patient vasopressor requirement started to downtrend after putting the patient on peripheral VA ECMO. Patient started improving 48 hours post commencing the VA ECMO. Now, there has happened some peculiar thing right now. Day 3 post commencement of ECMO, the SpO2 of right arm dropped to 88%. And you did the ABG from the right radial artery that confirmed the PaO2 of 45 millimeter mercury. So this is another complication right now or peculiarity right now that has happened. But when you check the SpO2 from other extremities, they were normal. Chest X-ray demonstrated right upper lobe atelectasis. Echocardiogram showed improvement of LV systolic function with well opening of aortic valve. So what has happened? So the peculiar scenario here would automatically right now, if you have seen this type of things or you have read it, then the question should follow. What is your diagnosis and what is the mechanism for such a complication? So this is Harlequin Syndrome. Saturation of upper part of this body is lower than the lower half. Why this has happened or why this normally happens? This is due to some competition happening in the aorta, and that is the flow competition. So there is the LV is right now recovering and trying to push the blood forward. But the ECMO circuit is right now taking all the blood and pushing the oxygenated blood. So there is mixture of the deoxygenated blood and the oxygenated blood. I would show you the picture in the next slide. Now, if this is happening, this is a peculiar complication. How will you troubleshoot this condition? So you have to increase the P per FiO2 to increase the the SpO2, optimize the ventilatory settings. If you still need ECMO support, maybe from the peripheral ECMO, VA ECMO, you have to think about or switching to the central cannulation, axillary or carotid. If heart has completely recovered, you have done the echocardiography, you are pretty sure that yes, we can think of decannulating. It is the time to decannulate. Otherwise, you will get this type of problems. Now, conversion to the VA-V ECMO, think of Impella as the alternative support. So these are some of the troubleshootings that would be coming to your mind. Now, this Harlequin syndrome is also known as North-South syndrome. And this is a peculiar complication, and you can see what I was trying to explain. So this right now deoxygenated blood from the LV and the oxygenated blood from the ECLS return right now mixing somewhere around the aortic arc. And this would be this watershed area. And this is also named as differential hypoxia. So this situation specifically occurs when the native LV function is improving on ECMO and competes with the upcoming stream of the from the femoral cannulation. So this battleground is drawn somewhere around the aortic arc, and it is a fight between stroke volume from the native LV and the ECMO return. So this is North-South syndrome or Harlequin syndrome. In short, if you want to see, this is the right radial artery. So you are getting the blood from here. So that would be something which is like this deoxygenated product from the LV and oxygenated product from the ECMO watershed area, and you are trying to get this blood, and you will get the SpO2 always or the PaO2 low in this region. Now, there is one question. What are the major trials on the VA ECMO as eCPR in the next one? So the answer to this is ARREST trial and CHEER 2 trial. So this would be the questions in the next the question in this clinical vignette. Now, the CHEER trial for all the students, this was published in October 2014, and in short, that has showed that ECMO for the refractory cardiac arrest shows promising survival rates if your protocolized care is applied in conjunction with predefined selection criteria. Just remember, this is CHEER 2 study, and that has shown that you have to think about ECMO for refractory cardiac arrest. The other one, this is the CHEER trial, and this is the ARREST trial. So these are the two trials that have shown that ECMO facilitated resuscitation for patients with out-of-hospital cardiac arrest or refractory ventricular fibrillation has significantly improved the survival to the hospital discharge compared with the standard ACLS treatment. Now, moving further to the next clinical vignette, you have stopped sedation. The patient was not waking up appropriately and now had upper motor neuron sign. You did the CT brain immediately because you have stopped the sedation, and you found in the CT scan this type of image. So there is one significant ICH that has happened in the ECMO patient. So now at this point of time, from pulmonary embolism, the examiner has tracked you to the ECMO. Now from ECMO, there has happened some complication, and in this complication, what are the risk factors for like ICH? You have to know about rapid hypocapnia, female gender, high pre-cannulation SOFA score, septic shock, pre-ECMO morbidity, thrombocytopenia around less than 25 to 30 thousand per ml, use of heparin, hemolysis. So this could be the risk factor for ICH in ECMO. What are the mechanism of ICH in ECMO patient? Low cerebral blood flow, hypoxia, acidosis, reperfusion injury, rapid shift in the PCO2 and PaO2 lead to the vasoconstriction that has happened and leading to the ICH. Prothrombotic conditions like the patient has landed up in sepsis, and that is also the one of the mechanism for the ICH in ECMO, and pre-existing anticoagulation antiplatelets that has resulted in ICH. So the questions from like the ICH would end up with risk factors and mechanism. Now, next clinical vignette, on day 5, the patient was decannulated successfully due to the recovery of the LV and the heart. Now, you held the sedation for almost 48 hours. His GCS right now is E1, BT, M2. His kidney functions improve, and his urea creatinine and liver function tests are within normal limit. He is making 30 to 50 ml of urine per hour. His last fentanyl dose was 48 hours ago and has been off propofol since. The bedside nurse right now at this point of time on examination found tonic roving movement of the eyes. His electrolytes are 148, 4.8, magnesium, calcium, phosphate levels are within normal limit. Now, you did the ABG, that is within the normal limit. He has no neck stiffness and has been febrile for last 48 hours. So this would be the next clinical vignette. Now, the questions would follow. What is your differential diagnosis at this point of time, and what is your provisional diagnosis for his encephalopathy? So the differential diagnosis would be non-convulsive seizure, progression of the IC bleed, any other intracranial event such as new ischemic stroke or subarachnoid hemorrhage. Now, how will you further evaluate this patient? You have to do one EEG to rule out non-convulsive seizure or something else what is happening in the brain, and also you have to rule out any potential drug that you are continuing with that is causing encephalopathy. So that would be the two questions in the next clinical vignette. And how will you treat this patient? So for the seizure part, non-convulsive seizure part, midazolam or lorazepam, you have to incrementally dose to like increase the dose to stop any clinical signs. Load with levetiracetam If still has ongoing seizure in the EEG, you have to add the other one, that is phenytoin, can consider lorazepam or valproate. You have to monitor continuously with continuous EEG. So that would be the treatment or management part at this point of time. Now, the next question, how does non-convulsive seizure affect, that means the morbidity, that is the length of stay, and mortality compared to the convulsive status epilepticus? So here, one important thing, we all know non-convulsive seizure is more dangerous. That means longer length of stay and worse mortality compared to convulsive seizure, because sometimes it gets so delayed in the diagnosis and the management part. So this ends the CCS1. So the patient started with acute pulmonary embolism, landed up in the ECMO management. In the ECMO, there happened some complications like in the neurosurgical domain. And in the neurosurgical domain, it again ended up with some or other monitoring and complications, that is non-convulsive seizure. And finally, the question ended with the few evidence-based structure questions about the non-convulsive seizure. So with this, we end the CCS. And I know it is little bit of like terrifying from the first one. The questions were a little bit difficult, but this was intentional to know or to let you know that the questions can come from different domains. Dr. Ramanathan, welcome.
Yeah, thanks, Tapas. Yeah, that was a very intriguing case. I would not be, I wouldn't want to be in the EDIC exam for a case like this. Clearly quite advanced level of management. And again, you know, see, the bottom line here is you cannot avoid or predict how difficult some of the questions can be. But essentially, you know, apart from the section on, say, some of the unique complications of VA ECMO, I would think most of the other things pertains to general critical care, management of a PE patient. And essentially, you know, things like how do you look out for, say, an intracranial bleed, management of intracranial bleed. All it shows is essentially, you know, the EDIC questions are structured in such a way that you need to, I mean, there is essentially a big stem, and you are essentially supposedly following that stem very neatly with a list of differentials, and the examiner will essentially, you know, tip you or pinpoint you, and you can use the clues given in your vignettes to further substantiate the direction in which you're going ahead. And 90% of the time, you know, you would go along the right flow to reach or to satisfy the examiner. If you take a wrong track, essentially the duty of the examiner is to get you or guide you into the stem again and make sure that, you know, you come up with more differentials or more suggestions. Few things to be careful about. I mean, this is in general. Answering an ED question is not about having verbal diarrhea. I mean, essentially, you know, you just need to be very succinct, pinpoint. Keep your answer short, but make sure that, you know, you cover some of the major points of the questions asked. There may be things which you would still miss, and the examiner might prompt you if you have missed it. Clearly, you know, that will give you more brownie points. But if you have already said what was expected of you, the examiner would just move on. And I think, you know, that's going to be important. And that's where, you know, when you start moving from, in this patient who had PE, to, say, general critical care management of the PE patient in the ICU, management of his mechanical ventilation, the thrombolysis, and all those bits. I think, you know, these are things which you should otherwise know. So clearly, you know, this is expected of you. And if you are unable to answer such questions, these are pretty straightforward questions which you can score heavily. While something like management of LV distension on VA ECMO, not all candidates might answer. So you can very well expect that such difficult questions, if it is going to be difficult for you, it's going to be difficult for many of the others too. And you may want to move on to the next set of questions where you might want to start scoring again. And at that point, whatever little you know about EB distension, you say that, and you can tell the examiner, I'll come back to this question later. Let's move on to the next set of questions. So then, you would then be surprised to find that there is a patient with intracranial bleed and how you manage intracranial bleed, and you have read anything and everything about management, ICU management of patients with intracranial bleed. So, the point I'm trying to make here is, don't get flustered by the complexity of the question. Everything eventually boils down to basics. If you stick to basics, you still will be able to hover around and move on to the next domain of questions which you might be able to answer. And that's how you face challenging, difficult situations in exam. So managing these small instances of what I think is extraordinary questions. It's sometimes, it's still worthwhile saying, I don't know. I don't know is a perfectly acceptable answer, and move on to the next rather than brooding over it. And I think, when you do that in such exams, you will find that you will come across more questions that you know, and you may be able to answer the entire set of questions that is required of you. But otherwise, I have nothing more to add to what Tapas has already elaborated. He's taken a master class on VA ECMO, and that was quite nice. At least you should be familiar with the concept, the indication, contraindication, the common complications. And mind you, even though the examiners bring in such novel concepts, they still would stick to some of the basics because they understand that not everyone of you would have managed such patients. So don't panic when you come across some difficult bits and pieces during your exam vignette. Thanks, Tapas.
Yeah, thank you, sir. So this I know this question setup, like what we have made, is like Dusra by Muralidharan. But yes, we tried to give you a wholesome, a pragmatic approach that in case you get this type of question scenario, just stick to the basics, what Dr. Ramanathan has clearly mentioned. And in after one or two questions, you will get again the fresh questions which would be easily answerable.
The curriculum of cardiothoracic and cardiology domain, I think Tapas is going to talk about it later on, just what you need to read, what you don't need to read. But specifically, my section of the CCS and CBS is touching on these things. So bit of a IABP, bit of a pacing, that is very, very important for the exam. Before going into detail, my name is Sananta. As I told earlier, I work as an intensivist in North Queensland, the place where there are a lot of crocodiles. But that's a very good place to work. So our course is in module 1 now. So we have 10 more modules to go, along with 3 mock tests that will happen each week, ending in the end of September, giving enough room or time to go through, revise again through the whole course. So you guys can have a month or so before your final exam. Now that's the first vignette we have in the CCS. So 71-year male admitted to ICU, post-mitral valve replacement with left atrial appendage ligation. He has a background of rheumatic heart disease, atrial fibrillation, and was on warfarin, which was stopped 5 days ago. He was maintained on heparin infusion in the hospital before the surgery. The left ventricular ejection fraction was low normal with a moderate RV dysfunction. His pulmonary artery systolic pressure is 65 millimeter of mercury, and on admission to the ICU, the following are the vitals. So that's the chest X-ray. You can see the mitral valve seated there. There is a endotracheal tube, sternal wires, couple of drains there, and some few ECG leads going here and there. There's no pneumothorax, bit of effusion on the left side. His heart rate is 60. He is paced VVI. His blood pressure is 80 over 46 millimeter of mercury. There is a low CVP, 2 millimeter of mercury. He's on a PRVC mode of ventilation with 0.5 FiO2, tidal volume of 500 ml, and his plateau pressures are acceptable at 24 centimeter of water. He has 2 chest drains, one in the left pleura, and the other one is a mediastinal drain. The drain output since arrival to the ICU last 1 hour is 250 ml. He is currently on 3 microgram per minute of noradrenaline infusion. Admission, blood gas, and chest X-ray are as following. So that's the chest X-ray, and that's the blood gas. On the blood gas, pretty much looks normalish, but with a low calcium level. PO2 is 117 with a FiO2 of 0.5. His lactate is near normal. Glucose is fine. Electrolytes are okay, apart from a low potassium of 3.7. So basically low calcium, low potassium with a normal looking blood gas otherwise. So the first question is, what are the possible causes of shock in this patient? So very, very common in the exam. If you get a septic patient, if you get a bleeding patient, if you get a cardiothoracic patient, if you get a cardiac patient, you will get a question on what is the possible causes of shock. This is the first question or opening over of the match. So they always start with what is the differential of the shock. So when they ask you about a differential of the shock, always mention about type of shock and what is the most probable one to start with. Okay. In this case, for my thought process, cardiogenic shock, probably because of the stunned myocardium post-surgery. He has a low paced heart rate also that can be contributing to the shock. There may be chances of pneumothorax or tamponade constituting the obstetric shock. He may be bleeding due to coagulopathy or surgical bleeding, so hemorrhagic shock, may be vasoplegic because of the post-pump scenario, or the patient may be rewarming, or he is on a hefty dose of sedative. And the fifth one is a hypovolumic, which is again due to the low fluid status or bleeding intra-op not being replaced. So always go for a systemic answer about shock and put the highest possible diagnosis or probable diagnosis in the front, and then go down the ladder. If you say, oh, it is a bleeding case, but you'll get only 1 mark for that and you'll lose 3 marks. So you have to have a structured answer. Make the structure before the exam rather than on the side, because on the side you'll not be able to. So that's why the practice of answering is important. Second question was, how will you distinguish each type of shock? So it can divert to anything. They can go into bleeding. And the bleeding patient in a cardiac surgery, they can ask you about the type of shock. They can ask you a few other things around it. So it opens the whole box of worm, and you can be asked any question. In this case, we decided to ask you about the shock. So how will you distinguish between the shock? Cardiogenic shock, first thing you do is a TTE or a TOE, depending on your facility and availability. Obstructive shock, you do either a lung ultrasound to rule out a pneumothorax or a chest X-ray. Tamponade, again, TTE and TOE, chest X-ray, narrow pulse pressure, rising lactate. All these things are signs of a tamponade. Hemorrhagic shock, the patient may be overtly bleeding, or there may be occult bleeding in other sites, such as in the chest or in the abdomen. Or hypovolemia, how do you rule out? Is by echo and looking at CVP, which is only 2 millimeter of mercury, though it is not reliable, but a trend may be helpful. So again, there is a structure to the answer that is most important in the exam. Now, how do you manage this case? So think of what you do practically. For a patient who is post-cardiac surgery immediately with a low blood pressure, who has a pacing rate of 60, has come to you, how will you manage? The first thing I will do is to increase the heart rate, because cardiac output is stroke volume times heart rate. So you have to increase the heart rate to 80 or 90 and see the effect if it is getting better. Now to assess what is the cause, you do an echo to see the fluid status, to look for any new LV dysfunction, which can be a stunned myocardium post-surgery, or rule out a tamponade, most important thing. If the patient is running on 50 of propofol, reduce it to some reasonable dose, right? So reduce the sedative if it is there. If the patient is bleeding, now go for the bleeding pathway. How do you do? So if you have a rotum in your practice, do a rotum to see what is correctable, what is not correctable, and rule out other possible causes of shock, such as if there is a baseline adrenal insufficiency, if someone is already on the steroid replacement due to any other disease and that you haven't done, or if the patient had ACE inhibitor just prior to the surgery, things like that. So start from the most important thing, the most immediate thing that you are going to do, and go to a process that I'll increase the heart rate, give some fluid bolus, take the echo machine to have a look at the heart to rule out any tamponade, any ongoing bleeding, and how is the fluid status of the patient. I will do a rotum if the drain output is high or more than expected to see if there is a coagulation deficiency, coagulation disorder. Again, the important thing I want to mark is how heavily these questions are scored, like 5 marks, 3 marks, 4 marks. If you just stop like, oh, okay, he's bleeding, I'll give some fluid and see the response, you'll get only 1 mark. You lose all those marks. So you have to have a process of answering these questions. What you do day to day in ICU, try to put those knowledge into that. Okay. Now the vignette 2, again, there is ongoing increased output from the drain, and he is also woozy at the drain insertion site. His rotum demonstrated the following. So I think I would say probably in European practice is not very dissimilar to where I practice in Australia. So we usually predominantly look at the rotum rather than the TEG. And I believe that would be if they are going to show you a point of care coagulation study, but they may show you a TEG graph rather than a rotum. But my bet it will be on rotum. If you're getting a point of care coagulation test, it will be a rotum. In this case, abnormality wise, as you can see, they are already marked with pink or red. So most important thing is to see the A5 in 15. The 15 A5 is 4 millimeter, which is less than the normal. So it refers to a fibrinogen deficiency. So what is the abnormality you can see in the rotum? So rotum shows a fibrinogen deficiency with a 15 at 5 minutes of 4, which is lower than the normal. And how will you manage? So if you see there is a fibrinogen deficiency, A5 is only 4, you manage it with fibrinogen replacement. Either you give cryoprecipitate or you give fibrinogen concentrate. And then after giving, repeat the rotum 15 to 30 minutes to see whether you have corrected it or not, right? That's the basic way how you approach this. The vignette 3 for this patient, post-rotum based correction, the bleeding slowed down. The noradrenaline requirement went from whatever it was 3 microgram per minute to 20 microgram per minute, and he was started on vasopressin to maintain a systolic blood pressure of 90 and a MAP of 60 to 65. His CVP has now rose to 13 from 2, which was earlier, with only 200 ml of crystalloid loading. Repeat blood gas show worsening metabolic acidosis with a pH of 7.14 and a lactate of 4.8 and a bicarb of 12. His last hour urine output has tailed off to 15 ml per hour, and his current vitals are as following. So heart rate, you have increased already to a VVI pacing, it's 80. There's a narrow pulse pressure of only 18. The saturation is 100 on a FiO2 of 0.4. The noradrenaline requirement has increased from 3 microgram to 20 microgram per minute, and you have started the patient on vasopressin. So basically someone who is worsening shock, with a hyperlactatemia at this moment, and his acidosis has worsened. So it's probably a worsening shock in this case, and looks like with minimal fluid loading, his CVP has gone up, his pulse pressure has narrowed down, and that is very acute change. It's a self-explanatory differential here. Probably it's a tamponade, right? So usually the cardiothoracic cases, they end up with either a cardiogenic shock due to LV dysfunction or a stunned myocardium, or it usually tails off to a complication of the surgery, such as a bleeding or a pneumothorax or a tension pneumothorax. So these are the expected question where the question stream will migrate gradually, right? So in this case, the patient has a tamponade based on the history that you get. So what is your next plan of action? So this is a possible tamponade. Now, how do you manage a tamponade in the ICU? Bedside echo or a short focused echo as soon as possible to look for tamponade physiology, and look for the other differentials such as fluid status and contractility. If there is a tamponade, then you need urgent surgical referral or activation of the code and preparedness to open the chest in the ICU. Or if the patient has acceptable blood pressure, but it is a downtrending one and you have time to wheel him to the theater, then open the chest in the theater. Depending on where you practice, what is the usual scenario there, you aim to be prepared to open the chest as soon as possible if there is a tamponade, right? Now, the next question was, describe the tamponade physiology and how do you explain the raised lactate in this case? So the tamponade can be questioned in many ways. So they can ask you about the physiology, they can ask you about how do you manage, they can ask you the procedure of how do you open the chest, because it is getting more and more acceptable that in an acute situation when the patient is peri-arrest or arrested with a tamponade, as an intensivist, you should know how to open the chest just to relieve the pressure there, right? So it is an acceptable or expected skill that the intensivists more and more are acquiring and they're expected to have. So they expect also a little bit of knowledge around cardiac surgery, cardiac arrest, and how do you manage all those things, right? So in this case, describe the tamponade physiology. So there is collection of blood in the pericardium, which is relatively a fixed structure, and there is restriction of atrial and ventricular filling. There is equalization of pressure in all chambers, and there is decreased forward flow from the heart. So basically 2 or 3 buzzwords there that you have to talk about. So pericardium is more of a restrictive structure. It cannot expand beyond a certain limit. And there is restriction to both atrial and ventricular filling. So restriction of filling, then equalization of pressure. This is the most important thing you have to tell. That's what drives the physiology of tamponade. And there is decreased cardiac output after that. Cause of lactate. So raised lactate can be due to low perfusion state. The patient has been hypotensive for some time, or it can be due to the congestive hepatopathy because of the back pressure, because nothing is going forward in the forward direction, right? There are other causes of hyperlactatemia. High dose of adrenaline or catecholamine can cause also. All right. So now going to Unit 4, the patient had a PEA cardiac arrest in next 5 minutes, which is all expected with a tamponade. And the question asks you, what is your management priorities, or what are your priorities? Now you have to be very practical in your answering. What you do, just tell it, right? Don't have to be very descriptive about the process because it will kill time. So you need to be very precise what you do, specific answer. There will be very less time for these type of question. They will be asking some important points in that. So in this case, enumerate your priorities. So ensure that the patient has 100% oxygen. Disconnect the pacing to ensure that there is no fine VF underlying. If it is a PA arrest and just the pacemaker is kicking off, then it can mask the fine VF. So in that case, sometimes you have to disconnect it. If there is a VF, then shock, or if there is a shockable rhythm underlying, then shock the patient and start the CPR. Be prepared for immediate chest opening. Just call an immediate chest opening call, inform the surgical and anesthetic team, arrange for blood and blood products, and rule out other reversible causes, which includes the 5 H's and 5 T's of the cardiac arrest algorithm. So very specific answer. Importantly, airway breathing pattern. So airway breathing circulation. In airway, the airway is already secured. The patient is on the ventilator. You may switch over to a bag mask in that, bag and tube method of ventilating, because with the CPR ongoing, it is difficult for the ventilator to ventilate the patient also. It is recommended to go to a bag ventilation for the patient. You have to disconnect the pacing. If you think there is a fine VF going on, then it will be amenable to shock. And then immediate chest opening and preparedness for that. At the same time, ruling out other differential for the shock, right? Now the question number 9, how quickly chest opening should be achieved? This is a theoretical question. So less than 5 minutes is the accepted, or is the expected time frame where the chest should be open in case of a cardiac arrest in pericardiotomy patient. And if it is achieved, if the patient is not achieved to have a systolic blood pressure of less than or more than 60, then it has to be done within 5 minutes of that cardiac arrest. Okay. Now, Vignette 5, the rhythm of the patient degenerates to VF. How do you manage this? So how will you manage? So here we are talking about the cardiac arrest algorithm for a patient who has a cardiac surgery. So post cardiac surgery, cardiac arrest, the algorithm is slightly different than what we do usual ACLS or ALS protocol. It is different from that. So this vignette aims to look at your understanding about the ACLS protocol or about the cardiac arrest protocol for a patient who had a cardiac surgery recently, which is slightly different from the usual one. So I will recommend for you guys to read that paper, which is already given in your study material earlier. Very, very important in terms of exam. You need to read that paper and know things in and out of that paper, because if you are going to get a cardiothoracic patient as a case in the exam, this will be there, very, very high percentage, right? Now, how will you manage? So in this case, the patient has VF and we do 3 stacked shocks in this algorithm, not like one shock in usual ACLS protocol. You do 3 stacked shock, one after the other. What is the recommended adrenaline dose? So we usually give 50 to 100 microgram in incremental doses, not like 1 milligram at a single go like the usual cardiac arrest protocol, because with the hypertensive response, there is a very high risk of worsening the situation, like a graft rupture or a valve rupture or something, the suture rupture. So in that case, we give small aliquots of adrenaline, 50 to 100 mics intermittently, depending on the response. How will you manage the ventilation? I talked about earlier, 100% oxygen, change to a bag ventilation, because it is more controlled compared to a ventilator, which will be interfering with the CPR or chest compression. And if possible, we can decrease the PEEP, because that will be a determinant for the preload to the heart. So switch off the PEEPs. It is recommended that you can decrease the PEEP, right? Now, how will you manage if the patient has an IABP in situ? This patient doesn't have, but they can have a patient on IABP who is arrested post cardiac surgery. So how will you manage? In that case, to enable the trigger of the IABP, you can change it over to a pressure trigger and continue the CPR as usual for a post cardiotomy patient, right? So they will be eager to listen about the pressure trigger. So change to pressure trigger. This is true for the old machine where you don't have an auto trigger, but for the newer machine, I think if the patient is in cardiac arrest, then probably it goes automatically if you're doing a CPR to a pressure trigger. So I haven't done ever to change a IABP machine to a pressure trigger, but that's recommended in the guideline. Vignette 6, the patient has the chest opened in the ICU and the return of spontaneous circulation is achieved. He returned to the theater for re-exploration and bleeder was found and secured. He is now back in ICU. His current vasopressor and inotrope requirements are as following. So vasopressin is still at a dose of 0.04 unit per minute. Noradrenaline is 25, so it has gone up again, 20 to 25. He is now on adrenaline at 10 mics. And his blood lactate level is measured and was reported to be 12 millimoles per liter, which is pretty high. What are the differentials of the lactatemia in this case now? Again, the same thing, shock and hypoperfusion. It can be due to a combination of all these things, so adrenaline effect plus the shock and hypoperfusion. It can be due to the congestive hepatopathy or ischemic hepatopathy that has happened during the shock and cardiac arrest. So these are differential for lactatemia. What is the physiology of hyperlactatemia due to adrenaline? So as you said, if you have answered about adrenaline, then the next question will follow. Why adrenaline causes hyperlactatemia? Just a basic understanding of the physiology. They may ask for these questions as a special marking question. So in this case, adrenaline causes an increase in sodium potassium ATPase activity, leading to increased lactate production in the glycolysis. And those lactate are not used up completely in the Krebs cycle, leading to a shunt of the lactate causing hyperlactatemia. Or you can say there is uncoupling of glycolysis to the TCA cycle because of excessive glycolysis that can happen with adrenaline. So that's the physiological basis why adrenaline causes hyperlactatemia. Now, Vignette 7, on day 2 of the ICU, stay. The patient was turned for routine pressure care, and he became hypotensive with the immediate 12-lead ECG showing the following. So what is there in the ECG? That will be the question. As you can see, there are pacing spikes, but not followed by a QRS complex. So the patient has lost capture, and the underlying rhythm is a complete heart block with a very low heart rate, right? So that's the underlying rhythm. Now, what abnormality can you detect? So loss of ventricular capture, that's the most important thing. The patient is bradycardic, that's an additional finding, and probably complete heart block also. How will you manage this acute crisis? So in this case, tell what you do usually in that case, okay? Don't have to be, as Dr. Ramanathan was saying, you don't have to have a verbal diarrhea there. Answer the question what you do usually in the ICU in such a situation. So in this case, the patient has already a pacemaker in situ. Epicardial pacing wires are there connected to a pacing box. So increase the pacemaker ventricular output, whatever it is, to the maximum possible because it is a capture issue. If unable to capture with a non-perfusing rhythm or BP, then start the patient CPR or start CPR. External pacing with maximum output and arrange for an immediate transvenous pacing if possible. If you can start, or if he is amenable to external pacing, then that is the next thing to do with the pads outside. Now, if nothing works, the patient has lost output or has a decreased cardiac output, and it is not responding to your usual immediate management, then consider again chest reopening. If the patient is going into a peri-arrest situation, again rule out other causes of possible refractory bradycardia, such as other electrolyte abnormalities that can cause it. So basically answer the way you do in the ICU. So first you increase the output of the pacemaker, then see whether there is a capturing rhythm or not. If not, then apply the external pacemaker. If it is not working, then you don't have much options. In that case, start to arrange for a transvenous pacing. If the patient is going into arrest, then probably reopening of the chest, and rule out other differentials for that. Now that finishes the CCS part. Any input from the faculties or anyone? I would be happy to answer, or if they can add something into that.
Very well explained, Dr. Sanna. I would request Dr. Ramanathan and Dr. Susruta. Dr. Susruta has joined. Welcome, sir. Dr. Ramanathan, would you please add anything to the discussion?
Yeah, sure. Sure. Again, another comprehensive case whereby you're, I mean, of course, this is one domain, again, which is quite popular in any exam, including the EDIC. And as Dr. Dash rightly put it, it can take any it can take any direction, because the stem is big, so you can expect it to go in any direction. So you need to be prepared for some of the commoner questions coming out of this domain. One is bleeding in a post-operative cardiac surgical patient, 2, cardiac arrest in a post-op cardiac surgical patient, 3, worsening shock state in a cardiac surgical patient, need for IABP, and essentially the whole set of questions on IABP, the waveforms and the way it augments, and the evidence for IABP in this context. So all these things are possible questions. Again, pacemaker is the other gadget that is commonly used in a cardiothoracic ICU. So the other gadgets would be mainly hemodynamic monitors. I see that you have a separate session on hemodynamic monitor altogether. So again, that can be attached to this particular set of vignettes, and you may find that you may start up with a cardiothoracic surgical patient in the post-operative ward, but the discussion eventually leads to PA catheter management of this patient based on PA catheter, measurement of cardiac output, and other things. So, or the last things, I mean, the few other things which it can lead to would be arrhythmias other than VF. So you can have a patient with an unstable AF management of atrial fibrillation and long-term management of these patients once they leave ICU or once they are about to be discharged from ICU. So again, the domain itself or the specialty itself is so vast that they can start off with one small spark and eventually go to another extreme which you might not even expect. So these are things which, again, one, you cannot be learning just before the exam. So you need to have seen some patients with some cardiac surgical patients at least, or at least have managed them to understand the basic set of questions that come by. And I think Sanatan has touched upon most of the questions that are popular in this domain. Things like hyperlactatemia in such patients in the postoperative period. It's a common problem we all face. And the way I look at it, or the way I essentially dissect when patients have hyperlactatemia and my registrar calls me, is I keep it simple. So the lactate can come from the heart. So the patient has either a pedia or MI. Other source of lactate is your liver. So ischemic hepatitis is one such possibility. The third source is your abdomen. So post CPB, they are at risk of ischemic gut. So again, lactate can arise from the gut. Then, in patients with IABP, limb is a source of lactate. So essentially, limb ischemia can manifest with hyperlactatemia. In addition to the routine causes of hyperlactatemia, whether it's type A, type B, and all the stuff. So in a post-cardiac surgical patient, these would be the four major differentials that I would project in addition to the other causes. Again, the trick here is come out with a list and see if the examiner can pull out the one in his grid. And hopefully you'd have mentioned it in the first attempt. If not, the examiner would still prompt you any other cause, or what do you think of the drugs used in this scenario, which could cause hyperlactatemia. And then, you would then come out by saying, adrenaline, NORAD, and all these things can cause hyperlactatemia. So again, it's about playing the cards properly. And I think, most of the other things have been discussed. So nothing much to add in this particular domain, but rest assured that cardiology and cardiothoracic domain, you cannot ignore it in an exam. Clearly, they are interrelated. Questions from one set would overflow to the other and vice versa. So be prepared with this set of questions when you prepare for your EDIC exam.
Yes, rightly said, sir. There is a question in the chat box. Is long infarct an appropriate answer for chest X-ray question?
Yeah, sorry about that. What was the question, Tapas?
Yeah, there is a question. Is lung infarct an appropriate answer for the chest X-ray question? Dr. Sanand, could you please go to the chest X-ray question?
Actually, there was no chest X-ray question.
Yeah, that's what I was also confused. So did he mean that?
This was just a chest X-ray, not a chest X-ray question, just to show this is the chest X-ray, but there's no lung infarct in that. So in any sense, I mean, lung infarct is, to me, it's not possible to diagnose on a chest X-ray saying it is a lung infarct. So it'll present as some sort of infiltrate or some sort of opacity in the lung, which has a very, very wide differential. So I don't think lung infarct is an answer to whatever question you are talking about. So I would say it is I don't think it is an option as a differential. Yes, you can. Yeah, like lung infarct due to pulmonary embolism can cause a necrotic abscess there. So that can be a sort of thing, but I don't think there is a differential for any question as a lung infarct. If that is pertinent the question, I can't understand the question either. So there's another one. It says in Rotem question there was aptem and heptem. There was, yes. So it is a panel of 4. So usually in my practice we get a 4 panel. So intem, aptem, heptem, and fiftem. Sometime the heptem is not there if it is not a cardiothoracic surgery patient. So depending on what you are looking at, which patient, you either do heptem or not. So if they are on bypass, we usually run the heptem. If they are bleeding on the bypass, then this is how we do it. But you may get a GI bleed patient with a rotum there, so he doesn't need a heptem there, so it will not be there. So it depends on what type of patient it is.
Yeah, one thing that you need to consider in a post-op bleeding patient is the patient's temperature post CPB.
Correct.
So hypothermia is one of the important things. So that's usually presented in the vignette, and you may skip it. When you read through it, you may find that they might have written that the temperature is 35.2, and in the rush of reading the question, that might not hit you hard, and you will soon find that the stem eventually expands into postoperative bleeding, and the examiner asks you what are the possible causes of postoperative bleeding in this patient, and hypothermia might be one of the answers that will be expected in the grid. I mean, some loose points here and there, but I know most of you would be prepared for such questions anyways.
In ROTEM, I have one question. In ROTEM, there were 4 images. So I was confused which one to see and answer.
The basic fundamental is you correct the fiftem. You start with the fiftem. So if you don't correct the fiftem, rest of the numbers don't matter. So you have to correct the fibrinogen first, looking at the rotum, right? So that's why the question was plotted to show you the 4 tem there and what you are going to work on. So first you correct the fibrinogen deficiency and see how the coagulation changes after that. So the first point we see is the fiftem, because this is the earliest thing that you look for. The fiftem comes within 5 minutes or 10 minutes, depending on which center you are practicing. So we do at 5 minutes and 10 minutes. So fiftem 5 and fiftem 10. So that is the earliest parameter that comes up on the machine, and that's the earliest thing you can correct. So first thing you have to correct is the fiftem. That's why. After fiftem correction with the cryo or fibrinogen, you repeat another rotum to see what is the response to that. And then probably the coagulation profile or coagulation coagulation display on the screen will be better compared to earlier, and then that will give you a better representation of what is happening. In that case, if the aptem is abnormal or if the heptem is abnormal, then you can think of, yes, this is going to happen. We have corrected the fibrinogen part of it. Let's see the second part or third part of the coagulation. The first thing you have to see is the fibrinogen level. That's why the answer was to correct the fiftem with the fibrinogen and cryo.
Okay, but this one you will explain later in some other class, like all in the...
We would try to, because that will take another 2 hours to explain the whole process of that. So we'll try to put a demo class sometime as a class to all of you.
On ROTEM. Okay,
Yeah.
sure. Thank you.
Okay.
All right.
So thank you, Dr. Sanand, Dr. Ramanathan. So just one quick information. Like, these are the topics you have to write during the debrief that you have to read after we finishes the debrief, because otherwise what will happen, each topic domain what we are discussing, like IABP, like pulmonary embolism, like ECG, like echo, like ECMO, it will all take 3 hours or 4 hours discussion. So we urge you all to go through all these topics, pick up important articles related to that, 1 or 2 review article or some basic article, and clear your concept in the meantime. Otherwise it won't be possible for anybody to take 4 or 5 lectures, and you will be also bored. So you have to clear your concept first, then come up with the questions so that we can discuss in that group. Okay. So without wasting further time, Dr. Sanand, would you please stop sharing so that I can share the screen? We have to be little bit in hurry so that we be finishing, because there are 25 CPS questions. We have to finish, then 10 or 15 slides about some of the important domains. Yeah. Okay, perfect. Okay, so forgot this. Okay, so we are starting with the CPS question number 1. So this was the question shared with you all. So the first question, what is the answer? Can anybody tell to me like right now, because we have to be little bit
Delayed.
interactive. Yeah, why you are telling the late? Yeah,
Late IABP inflation.
what will be the effect of late inflation?
Yeah, poor coronary flow, like diastolic blood pressure will not increase as expected. That will causes the poor compromised coronary blood flow, and there will be some backward supply to the other organs in the coronary. And
Okay. So excellent. So this opens up a panel of questions. So we have to know early inflation, late inflation, early deflation, late deflation, the high filling pressure, the plateau pressure of IABP. So there are a lot of troubleshooting. The questions can come from any domain. IABP is a very high yielding domain. I don't want to discuss because it will again take 2 hours just for the sake of completion. We have to discuss about the indication, the contraindications, the complications, then the normal IABP waveform, what are the troubleshooting, then many things which would be asked. So you have to read. So write in your paper, IABP will be one of the favorite domain in part 1 as well as part 2 of EDK exam. So as you rightly told, delayed or late inflation of IABP balloon, suboptimal augmentation of diastolic blood pressure, and inadequate coronary perfusion. Just for the sake of one quick clue. So with late inflation, the balloon inflates after the aortic valve closes. So you would get the diacritic notch is actually preceding the inflation point, and the notch and the inflation point create a W shape. So just remember, for the sake of if you don't have time, just see if you are getting a W, then it would be late inflation. If it is U, you would get something. So you have to remember in certain ways so that in case of you are having no time, you have to immediately pick up. Okay. So this is, you have to know what is A, what is B, what is D, what is E and F. Just for the sake of understanding, I have kept this picture. Not very much important. Now, so this is early, the late one we have already discussed. The early one I just showed. This is a U, big U. It's a clue, and yeah, it occurred prior to the aortic valve closure, indicated by the absence of the diacritic notch. And as a result, what would happen? So maybe there would be possible aortic regurgitation, and there would be also impairment of the left ventricular emptying because of this early intra-aortic balloon pump inflation. So as a result, what would happen? All the pressures would increase, like left ventricular end diastolic volume, end diastolic pressure, pulmonary capillary wedge pressure. And as a result, what would happen? So there would be increase in the afterload, and afterload, by that I am hinting towards the left ventricular wall stress. And as a result, what would happen? When there will be increase in the afterload, there would be increased myocardial oxygen consumption. So these are the two important things what I want to share, that is early and the late. So moving forward, so there would be what are the indications of IABP, then contraindications of IABP. So there are a lot of questions. I don't want to go into detail. Rather, I would be going into the next question. The question number 2 for the CPS. You got a call to see a patient on the ward who has a return of spontaneous circulation following a cardiac arrest. The patient is groaning. Now, on initial assessment, you find patent airway, bilateral equal chest movement. Just 1 second. Respiratory rate 18 breaths per minute, SpO2 94% on high flow oxygen, heart rate is 45 beats per minute, which is regular, poor pulse volume, blood pressure 57/30 millimeter mercury, patient is conscious but not fully alert, and blood glucose is 5.5. ECG done, which showed, yeah. So what is the ECG rhythm here, and what is the diagnosis, and what are the immediate treatment? Any answer? So in CBS, you will get hardly 1 to 1.5 minute time in one table. So you have to pick up the important clues from the question, the clinical vignette, what have been shared with you, and with the picture that would be shared. So any answer?
Yeah,
question?
complete heart block.
Okay. Diagnosis? That is not a diagnosis.
Diagnosis the same.
And what is immediate treatment?
Anyway, we have to start CPR because we have to give first atropine and then pacing, adrenaline, isoprenaline.
Okay, so the answer is complete heart block. You are right, and the diagnosis would be post cardiac arrest status, complete heart block, cardiogenic shock. The patient is in cardiogenic shock, so this would be the complete diagnosis: post cardiac arrest status, complete heart block, cardiogenic shock. And the treatment, that would be the immediate. You would start with injection atropine, maximum you would go up to 3 milligram. Injection isoprenaline, you can try with injection adrenaline, and then the final thing would be pacing, that could be transvenous or transcutaneous. So these would be the A, B, C answers. You have to be short and crisp. You cannot take much time because you have only 1.5 minutes to think about, answer the question, move to the next question, because there would be around 10 to 12 questions in each table. So there would be 3 tables, and you have to answer at least 25 questions out of 36 questions to get a sure shot like the passing in that CBS as a total. So you have to pass in as a total. The passing mark has to be more than what they have scored. Now, the next question: a 62-year-old woman has been admitted to the ICU with hypotension, bradycardia, following a 4-day diarrheal illness with vomiting. She is in acute renal failure with a serum potassium level of 6.9 millimole per liter. Normal range they have given here 3.5 to 5.3. Her medication history is unknown, and his ECG is shown, which is just a second. Yeah. So what is happening here? What are the abnormalities in the ECG? First question. And the second question: what is the most likely cause of the bradycardia?
It's like
ventricular bigamy.
Okay. What is the most likely cause of the bradycardia?
Hypokalemia.
Okay.
Hypokalemia.
There is a
Yeah, so there are the answers would be ventricular bradycardia, atrial tachycardia, AV block, reverse tick, ST segment changes. And the question particularly wants to know that this patient is on digoxin. 62-year-old man, hypotension, bradycardia, 4-day diarrheal illness, now landed up in acute renal failure, potassium is high. So now this patient is, you can see the reverse STT changes, the reverse tick sign in case of digoxin toxicity. So the answer would be digoxin toxicity exacerbated by acute renal failure. So you have to know what are the features of digoxin toxicity. Digoxin is notorious to have all the ECG changes. There are many ECG changes that would be seen in digoxin toxicity. It's not only reverse tick ST segment changes, rather it would be a plethora of all the ECG changes that would be presented. So few more questions. If you would get a question about the digoxin, maybe in the CCS as well as CPS, what specific treatment is indicated? Digoxin specific antibody fragments. Now, what 2 type of pieces of information that can help calculate the dose of the D5, that is the patient weight and serum digoxin level. What would be the other things that would be the adverse effects with or following the use of digoxin specific antibody fragments? They could present with allergic reaction, hypokalemia, rebound toxicity with use of digoxin specific antibody fragments, heart failure, arrhythmias. Now there could be a question: should digoxin level be monitored during or after treatment? No, because when you measure this, there would be little bit of false, because it would calculate both, measure both the antibody fragments that is bound to the digoxin as well as the free digoxin. So it would overestimate the free digoxin level. So rather you should not measure during the treatment or like after the treatment. Now the next question, a 52-year-old man has been brought to the emergency department having been found collapsed next to a canal. He is dressed in multiple layers of cold, wet and dirty clothing. He has heart rate of 48 beats per minute, BP of 88 by 54 millimeter mercury. The GCS score is E2M4V3. Now the paramedics have been unable to obtain a temperature reading and ECG done showed. So with this clue only, you are getting a hint that maybe the examiner wants to know about something related to cold, wet, dirty clothing, then unable to obtain a temperature reading and found collapsed. So the question here, yeah. So this is the ECG. What are the abnormality marked by the arrows? So they have made very particular, like they have given a hint. What are these waves? And the next question is, other than hypothermia, what are the other causes for this type of waves? And what changes are made to the advanced cardiac life support algorithm when you resuscitate a patient with hypothermia? The questions are like threefold. What is the abnormality? Then what are the other causes for this type of wave? And what are the changes that have been made? Any answers?
J point elevation and
Second question.
Second, other than hypothermia, it can happen in the early repolarization and myocardial like STEMI and then LVH.
Next, third question.
Changes made arming, like along with the CPR algorithm, we have to continue with the active and passive warming of the patient.
Okay. So the first question answer is Osborne J wave. Other causes: hypercalcemia, brain injury, subarachnoid hemorrhage, vasospastic angina, idiopathic ventricular fibrillation, type 1 Brugada syndrome, and normal variant, which is like early repolarization. Then the question number C, the third answer are no adrenaline or other drugs until the patient temperature is more than 30 degrees centigrade. Between 30 to 35 degrees centigrade, double the dose interval for the advanced life support drugs, and then shock ventricular fibrillation up to 3 times if necessary. Then no further shocks until the temperature is more than 30 degrees centigrade. So you have to aggressively increase the temperature at this point of time rather only giving the shock. So these are the answers to the ABC. Now moving further, what is this device? What is the purpose of this device? How it can be classified and what are the indications for its use? Anybody?
Tandem heart. Like this is a mechanical circulatory support and this is tandem heart. The purpose of this device is to unload the left ventricle, and it is comes under LVAD, like type 1, type 2, type 3. Indications for it.
Okay, so explaining further, it's a ventricular assist device, VAD, and the indication is to partially support or entirely replace the function of left or right ventricle. This part, like C answer is, it can be divided into how it can be classified. It can be classified on the basis of ventricle being supported, whether it is left ventricle, right ventricle, or biventricle. Mechanism, that could be pulsatile, non-pulsatile. Location, extracorporeal, intracorporeal, paracorporeal. And the driving mechanism, whether it could be the pneumatic, electrical, or magnetic. So on that basis, we can divide or classify the ventricular assist device. Now, the indications, the fourth question answer, again, you can divide into bridge to transplant, bridge to recovery, or destination therapy. Bridge to transplant, implantation of the VAD to support the patient with end-stage heart failure who is waiting for the heart transplantation. Now, bridge to recovery is implantation of the VAD to support the patient with a potentially reversible heart failure. So once the heart has recovered sufficiently, so you will be removing the VAD. Now, destination therapy, when you are like the patient is not a candidate for heart transplantation, so you are implanting the VAD to support the patient with end-stage heart failure. So it's like a portable VAD may be used in this situation, so that the patient may be discharged from the hospital and return home and spend the remaining life. So these are the indications of the VAD. Now, the next question, a 75-year-old patient with ischemic heart disease had been admitted to the hospital with just 1 second, something. Now, a moderate, the transthoracic echo shows the moderate biventricular dysfunction, and cardiac angiography demonstrates a chronically occluded right coronary artery with diffuse coronary disease. The drug history is bisoprolol, ramipril, spironolactone, and furosemide. A temporary pacing wear is inserted right now. So this is the question. With this question background, how could you describe the temporary pacing wears using the first 3 positions of the British Pacing and Electrophysiology Group generic pacemaker code? This is the question number 1. Then the second question, with reference to the pacemaker functionality, what do you mean by rate modulation? And the third question, what action should be taken when defibrillating a patient with permanent pacemaker? Any answer before I will explain? First 3 positions.
Like the chamber paced, the chamber sensed, and then the whether rate is inhibited or increased.
Okay, so it can be divided into 2 types, VBI, VOO. VBI is paced ventricle, sensed ventricle, and the I for inhibited if the native activity is sensed. So it's for demand pacing, VBI. Now, VOO is for fixed asynchronous pacing. That means patient's ventricle is paced, but there is no sensing. So this is OO. Now, the second one, what do you mean by rate modulation? The ability of the pacemaker to alter the rate based on the physiological demand. If the patient's demand is more, so if the pacemaker is able to alter the rate, so that means the pacemaker is able to modulate the rate. Now, the third one, for the permanent pacemaker, if you want to defibrillate, the defibrillator pads should be placed as far from the pacing box as possible. So this should be the point number 1. And then post defibrillation, the pacemaker must be checked to check like whether the pacemaker settings and functionality is still ongoing or not, or you have to like do something else to again make it functional like before. So these are the 2 things you have to keep in mind when you are defibrillating a patient with permanent pacemaker. I'm not going into detail of the discussion because we are running out of time. Now the next question is identify the abnormality and how will you manage this? This is very clear image and the answers I have written. This is pericardial effusion or suspicious of tamponade, because from this still image, it will be very difficult to answer whether the patient is in cardiac tamponade, and without a significant or like a short case like vignette, it little bit difficult. So we can answer in this way: pericardial effusion, suspicious of tamponade, and how do you manage depending upon the clinical scenario. But pericardiocentesis would be my choice at this point of time. Now, a patient with triple vessel disease undergone CABG. Post-op, patient is put on a mechanical circulatory assist device. Identify the device and identify the abnormality. I've answered it because we have already like gone through this type of discussion. So IABP and IABP tip is displaced upward. Why I am saying that this IABP tip is displaced upward? How will you check the position in the chest X-ray? What will be the landmark? Anybody? It's about 2 centimeters. Yeah, tell me. 2 centimeters from the carina is a correct position on a chest X-ray, right? And the IABP is inserted through the femoral artery, advance until the distal tip is in the descending thoracic aorta, preferably about 2 centimeters distal to the origin of the left subclavian artery. So that would be my landmark to put the IABP successfully. And you can check it in the X-ray because the distal tip is always a radio-opaque marker. Yeah, you can see here 2 centimeters from the carina, IABP. And it should be 2 centimeters distal to the origin of the left subclavian artery. just skipping. This is something we don't need right now. Yeah. 56-year male, chronic smoker with uncontrolled hypertension presented to the ER with acute onset chest pain radiating to the back. CT scan was done. Identify the abnormality. Management. Answer?
Aortic dissection.
Management.
Reduce the blood pressure. ABCDE approach. Reduce the blood pressure and heart rate. First the alpha blocker, followed by beta blocker. SBP 90. Blood aortic dissection.
Okay. Next question. A 45-year male admitted to ER with acute onset chest pain and shortness of breath for 6 hours. ECG taken in ER. What is the diagnosis and what is the definitive management? Any answer?
ST elevations in V1, V2, V3, sir, suggesting posterior wall MI. So reciprocal changes in the V1, V2, V3.
This is anterior wall MI, right? And the definitive management is PCI. Okay. What pressure is the blue shaded area represent? And what is the mechanism of action of IABP?
This is the assisted diastolic pressure. Augmented diastolic.
This is the area where the diastolic perfusion is improved to the coronaries. And mechanism of action of IABP, it decreases the afterload. That is the main mechanism of action of IABP. That's why the coronary perfusion improves, then the oxygen consumption decreases, and patient's diastolic augmentation happens. This is one drug. It inhibits phosphodiesterase 3 enzyme by decreasing the cyclic AMP hydrolysis. It works as an inodilator. Which drug we are talking about, and what is its effect on the right side of the heart?
Milrinone.
Okay, and what is the effect on the right side of the heart?
Improves the contractility.
And improves RV function.
Right. And it's a pulmonary vasodilator, reduce afterload for the right heart and improves contractility of the right heart. And it also reduces the preload to the right ventricle by peripheral vasodilator. So it's a pulmonary vasodilator. By that, it reduces the afterload for the right heart, and peripheral vasodilator reduce the preload to the right ventricle. Right. So with this, I end the first 12 questions. Dr. Sanand, any questions at this time? Dr. Ramanathan, sir?
Dr. Ram has to go. He had a call
Okay,
from the hospital.
No problem. So, Dr. Sanand, would you take
No,
it?
I think the main thing is in this cardiothoracic domain is your clear concept about pacing and IABP. So that you need to develop right now rather than leaving it for the exam. So in the exam, if you say, oh, before the exam, I'll do it, you'll not be able to do it because this is a concept developing thing. You practice the IABP curves, you practice the pacing rhythms, how they look, what is the abnormality regularly. Otherwise, in the exam, in the rush of a minute, you'll be telling the wrong answer. So the main thing why we have put it is to practice it, go through multiple waveforms of that, and make sure that you have a clear understanding right now rather than just before the exam.
Yeah.
All
So
right,
that is-
Tapas.
Yeah.
I think you are done with yours.
Yes.
So I'll be.
We are
going-
almost 2 hours past.
Yeah, rest of the questions very quickly. There is nothing to describe in those questions. So this was the bottles shown. What is the mechanism of action of the drug and right to important side effects? So protamine sulfate, it's a cationic peptide that binds to either heparin or low molecular heparin from a stable and forms a stable ion pair, which does not have anticoagulation activity. So reversal. The side effects are anaphylaxis, pulmonary vasoconstriction, bronchoconstriction. People can have bradycardia. It can negatively impact the platelet function. There is interference with the coagulation factor and decreased thrombin fibrinolysis. Someone was asking about the ratio, the aptem to Heptame ratio. So that is an important thing for protamine excess. So you look at the ratio, and if the ratio is more than 1.25, we say it is, sorry, if the ratio is less than 0.9, we say it is a protamine excess. So we'll go through all these things in a structured class on ROTEM. So protamine you can get as a side effect, as a mechanism of action, and what is the effect on the ROTEM if there is a protamine excess. 73-year-old male to ICU, came to ICU post aortic valve replacement and 1 times cabbage. His mediastinal drain continued to have a high drain output, so bleeding. His blood gas is as following. You have asked for a ROTEM, which is again 20 minutes. It will take 20 minutes to come back. So what is the abnormality in the blood gas that you can optimize, awaiting the ROTEM result, and what is the mechanism of such disorder in post-cardiac surgery? So the abnormality here was a low level of ionized calcium, which is an essential factor for coagulation. So more of a vigilance question, that you see a report and make sure that what does it mean in the context, clinical context. Somebody is bleeding with a low calcium, you need to supplement that. Optimize the calcium is the answer. And why the calcium level is low post bypass or post cardiac surgery? It is because of multiple transfusion that causes chelation of the calcium. Then again, another ROTEM question. The same patient as above continued to bleed post optimization of hypocalcemia. His ROTEM is attached. What is the defect you can see here? So again, you can see the 50MA5 is 5, which is just at the low level. So not optimal for a cardiac surgery, post cardiac surgery patient who is bleeding, probably will look for a higher A5. So in my practice, I'll just correct the A5 or correct the fibrinogen deficiency to start with. Usually that fixes the whole coagulation cascade after that. So there is the thing that is abnormal here is the fibrinogen level, so needs to be replaced. So fibrinogen deficiency, either you give the fibrinogen concentrate or give cryoprecipitate. 70-year-old male presented with left-sided weakness of the body with right facial droop. He also has painful red raised lesion in the hand and feet as seen in the picture, which have been progressive for last 3 weeks, along with feeling unwell, low-grade fever, generalized malaise, and body ache. He has been treated with systemic prednisolone by the GP for last 2 months for polymyalgia rheumatica without much improvement. On auscultation, he has a loud pansystolic murmur over the precordium. That's the picture. What is this?
Genuine lesions.
All right. So what are the skin lesion consistent with? And what is
Infective
your
endocarditis.
if it is painful, if it is painful, it is Osler. If it is not, then it is Genway's lesion, isn't it? Osler nodes are painful, Genway's lesions are non-painful. What are the other lesions that you can see in an infective endocarditis? In the eye, Roth spots. You see that. Osler nodes are thought to be immunologically mediated, whereas the Genway's lesions are caused by septic microemboli, right? Bit of a medicine question. For the above patient, what is the indication of urgent surgery and what is your empiric antibiotic plan? What is the indication for urgent surgery in infective endocarditis?
Periannular abscess, block, and if it is increasing in size, then we have to involve the cardiothoracic surgeons.
No, this so very specific answer. This is a CBS question, very specific answer. There are 4 main indications up to date. So early surgery in infective endocarditis if the patient has heart failure, uncontrolled infection, and prevention of embolization if the patient has embolic episodes, right? So these are the main 3 indications. So heart failure, uncontrolled infection, prevention of embolization, such as neurological complication if the patient has already neurological complication. If there is a prosthetic heart valve, valve infective endocarditis, then there is early surgery is indicated, right? So these are the indication, 4 more major indication. Heart failure or symptoms of uncontrolled heart failure, uncontrolled infection, still has blood culture positive in spite of a good trial of antibiotic, and if the patient has embolic episodes, or if the patient has prosthetic valve endocarditis. Empiric antibiotic, benpen, flucloxacillin, gentamicin, plus or minus vancomycin, whatever you have. Or depending on, this is the usual standard recommended medication, not to the Indian standard though. So you are appearing a European exam, so it will be benpen, fluclox, gentamicin, plus or minus vancomycin. That's the ideal answer. But if you say we treat with meropenem, vancomycin, and something else, in my practice, because you have to tell the reason, because of highly resistant organism is the most common organism, something which you have to give a rational explanation to the examiner. All right. Okay. Pacing abnormality demonstrated above rhythm, what will you do? So again, the temporary pacing. So it is not able to sense. It is pacing everywhere. So it is pacing here, not able to sense the QRS complex, pacing here, not able to sense the QRS complex. So pacing irrespective of the QRS complex. So it is not able to sense. How do you treat? So make the sensitivity threshold or decrease the sensitivity threshold. Okay. This is a reverse relationship. So if you dial up, then the sensitivity decreases. If you dial down, then the sensitivity increases. Okay, increase the sensitivity threshold. That's how you treat. This one, what is the pacing abnormality? Can anybody try that?
Following a pacing, there is no
So not able to
QRS
capture.
spike or no capture.
So not able to capture. How do you do it? So increase the capture threshold. So if it is at 5 millivolt, then increase to 10 or 15 or 20, whatever. So increase it and see what is the response. Patient on VV ECMO, ECMO for refractory hypoxia. Comment on the color of ECMO blood in the circuit in below, depicted in images A, B, and C. All right. So normal dark color. So A is normal dark color blood in drainage cannula and red color blood in the return cannula. So that's the drainage side. So these are three different scenarios. This one is the drainage, that's the return, that's a VV ECMO, which is normal, right? So the drainage is darker than the return is bright red, right? That is oxygenation is happening. What is the abnormality in figure B and figure C? What is it?
B is oxygenator failure. And C
Right.
is recirculation.
Yeah. So if both are red, it is recirculation. If both are black or dark, it is hypoxia, oxygenator failure. Good. 79-year-old female presented to a general practitioner with chest discomfort and a flu-like illness. Past history of included hypertension controlled with hydrochlorothiazide, captopril, and has vaginal thrush, for which she is taking ketoconazole. She was also receiving digoxin 0.25 milligram daily. Allergic rhinitis and flu-like illness was diagnosed and treated with a non-sedative antihistamine. So she then experiences a number of syncopal episodes and presented to the emergency. Clinical examination, shows she is well perfused, normotensive, but there are bursts of irregular pulse when present. So what is your diagnosis? Any comment on it?
Torsion is the point is.
Polymorphic torsion.
IV magnesium treatment of choice. Okay. 40-year male, heart rate. HR executive comes to routine investigation for insurance, and that's the ECG that is handed over to you. What is the diagnosis?
Type 1 heart block.
Some ST T-wave elevations are seen.
All right. So lead reversal,
Lead
nothing to
reversal.
be done in this patient, right? So that's the problem. You know this ECG. You can, if I give you 3 minutes or 4 minutes, you can tell me the answer, but that has to be answered within 1 minute. So there should be a structure to approach the ECGs. I'll tell you quickly about it at the end, right? This one, 28-year male, known carcinoid syndrome, presented with vomiting, shortness of breath, tachycardia, palpitation. Multipara monitor revealed the following: finding and intervention. ECG looks
So there is,
fine.
pulmonary artery pressures and CVP is raised with associated hypoxia, sir. And ETCO2 is also raised, right?
Yeah, so
And CVP wave typically shows
just-
there is carcinoid syndrome.
yes, link the dots. So carcinoid syndrome with a high CVP which looks abnormal, what it can be is right-sided heart valve involvement with a TR. Sorry, right? So fusion of C and V wave suggestive of TR associated with right-sided carcinoid in heart. What will you do? 2D echo and surgical review. Okay. So carcinoid involves the right side of the heart. You will have severe TR. In that case, you may need to replace the tricuspid. Which of the following pulmonary artery catheter waveform represents the catheter's normal location? A is what? CVT.
Atrial.
Yep, atrial. B is?
Right
So
ventricle.
right ventricle.
C is?
Pulmonary artery.
D is?
Pulmonary capillary.
Wedge, right?
Which?
So D.
Wedge.
Okay. Last one, 70-year female widowed presented with syncopal attack in emergency cardiogenic shock, troponin positive, angio normal, provisional diagnosis. 70-year female widowed.
Tacus.
So these are all important things to the
Stress
diagnosis. Takotsubo.
LV,
Tacus.
stunned
Balloon.
myocardium, sir, LV contractility with dilated IVC.
Apical
So
balloon.
poor LV
Stress.
contractive with a dilated left ventricle.
No, diagnosis, just tell the diagnosis.
Takotsubo
Tacotis.
cardiomyopathy.
Tacotis.
Takotsubo.
Takotsubo
Takotsubo, right.
cardiomyopathy.
Management,
Vasopressin.
usual heart failure
Supportive.
management, vasopressor inotrope. Rule out any ischemic heart disease, which is the major thing for a Takotsubo diagnosis. If you diagnose, it should be ruled out. The ischemia should be ruled out, and heart failure management usual, right? I think that's pretty much. So I was talking about the ECG. Just go to in the exam quickly. If there is an ECG, how I approach is they should be 99%, they will be in this 5 pattern. Either it is a arrhythmia or peri-arrest rhythm or a heart block. The second is a ischemic rhythm. The third is a metabolic rhythm. The fourth is a temporary pacemaker rhythm. The fifth is a syndromic rhythm. These are the 5 rhythm I look for a ECG when I am given an ECG, right? Either it will be arrhythmia or peri-arrest rhythm, or there is ischemia there, or there is something metabolic thing that is causing that ECG, or there is a pacemaker rhythm, or there is a syndromic rhythm, any syndrome, right? So you look at the ECG. For example, the one we saw, right? It looked normal. There is some STT changes, but it was not significant. So all the ECG will have a significant thing that is given to you. So that was not a ischemia, and that was regular heart rate, right? So I don't think that was fitting onto this. Ischemic rhythm, yes, somebody said it was ischemia, but only T-wave inversion, they will not give you in the exam as a T-wave inversion as ischemia. Either it is a STEMI or a significant non-STEMI or a posterior wall or inferior wall MI that will get. So it is not a ischemic rhythm. Metabolic rhythm, yes, it can be. You don't know, but what are the metabolic rhythm? Hyperkalemia, hypokalemia, hypercalcemia, hypothermia, digoxin toxicity, and TCA toxicity. I don't think that rhythm was any of those, right? Because it didn't look like hyperkalemia, didn't look like hypokalemia. The QT segment is okay. There was no reverse tick sign, and TCA, no RVR or RSR pattern there. So I don't think it was a metabolic rhythm. Now, temporary pacemaker, there was no pacing spike. So that was not the thing. So it can be something which is unusual, right? Either of these syndrome, right? Valencine, no, it is not. Brugada, no, it is not. Short or long QT, it is not. WPW, no. Was there a S1 QT3? No. Was there any alternate large and small spikes like a pericardial effusion, it is no. What is left with? Probably a dextrocardia. How do you look at a dextrocardia? Is it positive? How do you look?
Positive lead in AVR, no?
Was it there?
No.
Have a look.
No, yeah. Should be a
Right.
negative lead in AVR. It's a positive lead in AVR.
That's a AVR. That's a positive lead. So looks normal, no arrhythmia, no ischemia, no QT prolongation, no J wave. What is it? It is something which is abnormal, like a syndromic ECG. So no Valence sign, no Brugada syndrome. Then the AVR positive. Yes, it is dextrocardia. So that's how I look at the ECG in the exam. I put those 5 things, and 99% ECG will be within that 5 things. You just try that method. If you think it is effective, then continue with the exam, right? Otherwise, you develop your method of looking at the ECG to solve it within 1 minute. All right, that completes the session today. We are running over time, so I will not waste much time. It is already 1:30 here. So I will probably conclude, Tapas.
Okay, perfect. Thank you. Very well explained.
So any other questions we can discuss in our chat group, okay?
Yeah.
So we
So
can send
we
in the
have many
questions in the
things.
chat
I
group.
have like almost 15 more slides, but I don't want to like make it so exhaustive. Better you got an idea, an overview of like what are the questions normally asked. We were very thorough in the CCS. We have given you the domains which you can like start building up your own question bank, so that during the last 1 month time of your preparation, you will be just revising those questions and those like clinical pearls. So try to have your own method of like making the questions, scenarios, CPS, wherever you like see any type of like the monitoring like ECG or some atypical APG or something like Rotem, some like the TAG. Try to get all these things which are available in the form, the free online materials, and start making your own question bank. Otherwise, in the last month, there are people who ask, what should we read? So that is the question which we do not want from you all. Rather, you should say that we have our own stock ready for the last month. So don't take it the stock for other way. It's the study stock. Okay. So better like you get one idea and start building up your own confidence by preparing all these questions gradually. So thank you everyone.
Thanks,
And
Tapas. And I'll request the group to send any feedback that you want in the next class. We'll try to incorporate that in the WhatsApp group. Okay.
in the WhatsApp group, try to like interact with other people who are also preparing for the EDIC part 2 as well as part 1, and make it so interactive that you can clarify your own doubts with your fellow colleague rather than only going through this text and the websites and everything. Thank you, everybody. Good night. Thank you for staying for almost more than 2 hours, 2.5 hours. And thank you all the mentors. Thank you, Dr. Sanand. We will be meeting you soon for the next domain. So the trauma and toxicology is coming up. That is again a very important domain, and believe me, that would be something which you will be getting one CCS and multiple CVS questions for sure. And if anybody is interested in our course, please let us know. We would be definitely happy to help you. Thank you all. Yeah, take care.
Thanks, Tapas. Thank you all. Good night.